Hello and welcome. Today we're diving into the world of nephrology to explore a fascinating condition known as minimal change disease, or MCD. It's a leading cause of nephrotic syndrome, especially in children. We'll break down what causes it, how it affects the kidneys, what to look out for, and how it's treated. So let's get started! Minimal change disease, as the name suggests, doesn't always have a definitive, easily identifiable cause. In most cases, it's considered idiopathic, meaning we don't know the exact trigger. However, several factors have been associated with its development. These include recent infections, such as upper respiratory infections, certain vaccinations, non-steroidal anti-inflammatory drugs and NSAIDs, and even Hodgkin's lymphoma in rare instances. Some researchers believe that MCD might be triggered by an immune system response to these factors, but the precise mechanism is still under investigation. The key to understanding minimal change disease lies in the glomeruli, the tiny filtering units within your kidneys. Normally, these filters prevent proteins like albumin from leaking into the urine. In MCD, the glomeruli appear normal under a standard microscope, hence the name minimal change. However, at the cellular level, specifically at the podocytes, the cells that form the filtering barrier, there's effacement or flattening of the foot processes. These foot processes are normally intricate and interdigitated, but in MCD, they flatten and lose their structure. This structural change increases the permeability of the glomerular filtration barrier, leading to massive protein leakage into the urine, which characterizes nephrotic syndrome. Minimal change disease is the most common cause of nephrotic syndrome in children, accounting for about 80–90% of cases. While it primarily affects children between the ages of 2 and 6, it can occur in adults as well, although it's less frequent, accounting for about 10–25% of adult cases of nephrotic syndrome. There doesn't seem to be a significant difference in prevalence based on race or ethnicity, although some studies have suggested a slightly higher incidence in Asian populations. The hallmark of minimal change disease is nephrotic syndrome. This presents with a constellation of symptoms. The most prominent is edema, or swelling, particularly in the face, around the eyes, ankles, and abdomen. This swelling occurs because of the protein loss, specifically albumin, which leads to a decrease in the oncotic pressure in the blood, causing fluid to leak into the tissues. You might also notice foamy urine, a result of the high protein content. Other symptoms can include fatigue, weight gain due to fluid retention, and decreased appetite. In severe cases, patients can experience shortness of breath due to fluid buildup in the lungs. Diagnosing minimal change disease usually involves a combination of clinical evaluation and laboratory tests. A urine test will reveal high levels of protein, confirming proteinuria. Blood tests are also essential to measure serum albumin levels, which will typically be low, and to assess kidney function. While the diagnosis can often be suspected based on clinical presentation and initial lab results, a kidney biopsy is often performed, especially in adults or cases that don't respond to initial treatment. Under a light microscope, the glomeruli appear normal, hence the minimal change. However, electron microscopy reveals the characteristic effacement of podocyte foot processes. Immunofluorescence studies are typically negative, meaning there are no immune complexes deposited in the glomeruli. Generally, minimal change disease is not classified into distinct subtypes. It's largely characterized by its unique histological finding of foot process effacement and its clinical presentation of nephrotic syndrome. The cornerstone of treatment for minimal change disease is corticosteroids, typically prednisone. These medications work by suppressing the immune system and reversing the podocyte damage. Most children respond well to steroid therapy, and remission is often achieved within a few weeks. However, relapses are common, and some patients may require multiple courses of steroids or other immunosuppressants, such as cyclosporine tacrolimus or mycophenolate mofetil, to maintain remission. Supportive care is also important, including a low-sodium diet to reduce fluid retention and diuretics to manage edema. In some cases, ACE inhibitors or ARBs may be used to help reduce proteinuria. Unfortunately, there's no definitive way to prevent minimal change disease, given that the exact cause is often unknown. However, avoiding unnecessary use of NSAIDs and promptly treating infections might help reduce the risk in susceptible individuals. Furthermore, it's crucial for individuals with a history of MCD to be aware of potential triggers, such as certain medications or infections, and to seek prompt medical attention if they experience any symptoms of relapse. The prognosis for minimal change disease is generally excellent, especially in children. Most patients achieve remission with corticosteroid therapy, and kidney function typically returns to normal. However, relapses are common, occurring in up to 80% of children and a smaller percentage of adults. Frequent relapses can lead to steroid dependence or steroid toxicity, requiring the use of alternative immunosuppressants. In rare cases, MCD can progress to chronic kidney disease, particularly in adults with underlying kidney problems or those who don't respond to treatment. Current research focuses on identifying the specific immune mechanisms that trigger MCD and developing more targeted therapies to minimize side effects and prevent relapses. Recent studies have explored the role of B cells and T cells in the pathogenesis of MCD, paving the way for potential new treatments that target these immune cells. The ultimate goal is to develop a more personalized approach to managing MCD based on individual risk factors and disease characteristics.